Hi, good morning, everyone. Welcome to Mind Story Monthly Awareness Talk. So before I start, my name is Charlie. I'm a registered counselor with Mind Story. So let me introduce a bit about Mind Story. So in Mind Story, we provide services for children with special needs or children with difficulties in areas like academic, sensory, developmental delays, behavioral and emotional difficulties, as well as physical delays. So in Mind Story, our team are from different background. We have academic support, which is a special education teacher, behavior therapist, a clinical psychologist, a counselor, occupational therapist, reading therapist, as well as physiotherapist. You can contact us at WhatsApp us at our office mobile phone number. You can email us at admin@mindstory.com.my if you have any inquiries or suggestion for our monthly awareness talk. And also we are operating on Monday to Friday, 8 a.m. to 5 p.m. We also open on the weekend via prior appointment only. And we are closed during the public holidays. Okay, you can check us out at our Facebook page at mindstory.my. This is where we upload our monthly awareness talk or any short courses available on the following month. Okay, and you can check out our website at mindstory.com.my, our Instagram, mindstory.my, and our LinkedIn, Mindstory, Pusat Latihan Kanak-Kanak Berkeperluan Khas. Okay, so today we have a special guest, Dr. Aili, who is a child, adolescent, and adult psychiatrist, to share with us about mental health difficulties in children. Why we have this topic is because previous months, we have parents requesting, and also there's a trend that we see in Mind Story where children from the age as young as 5 years old, 6 years old, they have screened by a pediatrician, and there is no like diagnosis on any difficulties, but they were referred to see a psychiatrist. So because a lot of pediatricians, they are not specialized in, they doesn't have specialty in emotional or mental health. So this is where they will refer to a psychiatrist. Also here in Mind Story, we have seen that I personally assume that it can be due to the MCO 2 years, where a lot of the child are not exposed and they have difficulty regulating their emotion, which is one part of mental health. Hence, today we have this topic with Dr. Aili to understand more about mental health difficulties in children, because it's something in Malaysia that it's stigma, we don't normally open up and talk about it. And today we have a special guest, Dr. Aili. Hi, Dr. Aili, you there?
Yes, I am here.
All right, yeah. So we have invited Dr. Aili, who are in this field for many years. She's a psychiatrist for children, adolescent, and adult. So for those who have any question, feel free to put in the comment box in the Facebook so we can bring it up to Dr. Aili. Okay, Dr. Aili, you can start.
All right. First and foremost, thank you very much, Charlie and Mind Story, for inviting me. If I heard what you said about psychiatrists just now, then I might think twice about presenting today.
Yeah.
Maybe I could have missed what you were trying to tell me earlier. Maybe, I'm not sure.
Yeah.
And I must say though, thank you very much. And this will be my first live stream event.
Yeah.
So apologies if I'm a little, yes.
Yeah.
Keko.
Yeah, it's okay, no problem. Yeah, because the reason why we have this once a year, we have we will try. I personally run a few live talk on mental health, but as a counselor, not so much in diagnosis and not so much in psychotherapy. And also that's the reason why we have invited the psychiatrists, and also to diffuse the confusion among parents. Yeah, because a lot of parents that come to us, and then when they heard, oh, why my pediatrician asked me to see a psychiatrist? Why? It's not like my child is crazy, right? So they use this term, which is quite heavy sometimes. So I need to explain to them in a way that, it's not about being crazy, it's about mental health. So one of the obvious characteristic is difficulty in regulating their emotion. For example, crying for long hours, unable to accept, unable to share or with other children when they play, and then they get angry very fast. But there is no other underlying medical factors. Okay, for example, the child is not diagnosed with autism, is not diagnosed with ADHD, but somehow they are experiencing some difficulty in mental health wise. So this is where I explain to the parents, this is seeing a psychiatrist is not a bad thing. It's just to rule out any psychological or psychiatric related difficulties. Yeah.
All right, thank you very much. Can I start?
Yes, sure.
Yes. So I as what I said, I'm not very familiar with this. So there will be no Q&A or something like that?
There will be at the end, because I have some questions as well collected for parents.
Okay, because I put periodic pauses in my presentation.
Okay.
So that, as what you told me earlier, right? This will be very seldom that you guys invite a psychiatrist. So I thought I'll have some pauses just to give opportunity to people. Yeah. Okay, hang on, just
no problem.
To ask questions. Yeah.
Okay,
let me share screen. Okay. I suggested this topic partly because it's what Charlie had explained, because I think there is a misunderstanding of the term of mental health difficulties in children, right? And yes, I am a psychiatrist. The difference here is that psychiatrists, we have to take up our medical studies. We have to go through the sciences. I'm not particularly sure. I think psychologists are mainly, I might be wrong, apologies for this. They study more on human development. But we do, as psychiatrists, we are the opposite. I think our human development is maybe less than 50%, but a majority of it is about understanding the medical or the sciences behind why somebody falls ill, or how medication works, and so on and so forth. And then, as a child and adolescent psychiatrist, again, there's a difference between an adult or a general psychiatrist and a child and adolescent psychiatry, whereby we have to take, as a child and adolescent psychiatrist, we have to take the adult or general psychiatry first, and then we subspecialize to do child and adolescent. So it's a little longer in terms of learning, and the experience, definitely very, very different, including the cases that we see in children. Again, it's different from what we see in the adults. Okay, so these are my experience from years of doing child and adolescent psychiatry, that it is often misunderstood, it's minimized, or it's dismissed, and with grave consequences. The reason being because is that whatever it is happening in children, it is distressing and disabling. It affects not only the child, okay, and when I say child here, it means children below the age of 18, which is the WHO classification of children. So when I say child, it includes those in the adolescent stages, right? Not only does it affect the child, but others as well indirectly. And you can see the others would be the family members, the friends, and so on and so forth. Now, the number of affected individuals is raising, right? And this is not just because of the pandemic. Even before the pandemic, right, we can see the numbers of affected individuals is rising up to the extent that I think most government hospitals had seen a significant increase in number of children seeking help. And thus, we could see that the mental health services are inadequate. And this is despite the Ministry of Health opening up many psychiatric child and adolescent services in major
Hospital.
cities, major town cities in every state. I think that what they have not yet done, but hopefully they will, in the East Coast, East Malaysia, sorry. Now, many of these disorders, for example, anxiety, depression, it is actually preventable, is treatable, yet it is not detected. Okay, and of course, what we know is, the stigma attached to it, the stigma of being. And I think part of the stigma is this worry of, one, will my child be medicated? Two is, people talk about, am I going crazy? Right? And even that notion itself, it drives us to be very scared of visiting a psychiatrist, right? Whereas, you see, I will talk about it later, how it is the spectrum of disorders. Unfortunately, it is being placed under mental health disorders, not by psychiatrists, but these are international classification, right? We have from the Europe and we have the American, which we adopt in the local scene. Yeah, and of course, the pandemic, the war, and I must say the increasing level of aggression, again, that I see in many of the families that I treat. Okay, let's stop first the definition of mental health before we talk about difficulties. Yeah, and mental health is the way that we think, we feel, and how we act, right? In order to face life situations, including how we handle our stress, how we face our challenge, whether we can adapt or how do we adapt to the challenges that we face. And don't forget, stresses are individual. So even as a child, for example, you will face stresses in school, making friends. Yeah. So you can see at all levels, there are stresses, right? So we can't say as an adult what stress as a child has. They do have stress. And one of the main stress is this interaction with other people. And I've seen it through the years. It's not just in the homes, but school is very, very difficult. Right? It can be very challenging in terms of interaction in school. Yeah?
Yep.
So you can see, so instead of me telling, I thought, okay, now that you know the definition of mental health, so my question is to all of you is, where do we learn these skills? Right? When do we learn these skills? Right? And in the very stages that we learn, how would it affect one's learning? What are things that would also affect one's learning of these skills that we need to think, to feel, to act, to think about how to handle our stresses or how we handle our stresses? So where do we learn? When do we learn? What do we learn? And what are things that will affect our learning of these skills? Right? In fact, if I want to be really good, I can end my lecture here, because this is again a very good discussion in terms of
yes,
right
it is.
And what Charlie said is true. How the pandemic has changed the scenario of mental health difficulties in people that we see. Yeah. Okay. So then that's mental health definition, right? So when we talk about mental ill health, we can talk about problems versus disorders. What does it mean? Problems they do have problems managing themselves, learning, for example. But it's not so severe, right, to become a disorder. Right? When it is severe and persistent, and it lasts for a very long time, then we can define it as a disorder. So I think for some of you, all of you can understand that a problem may start small. If we had done something about it, or if we could do something about it, right, it might not be so severe and definitely not persistent. Yeah. So you can see this, the definition of ill health has got nothing to do, or there's no words as going crazy. Right. Yeah. But I actually like this and I think I think it's also seen in other countries, whereby they start as problems, so therefore they don't see the psychiatrist first. They go and see, like Charlie said, they see the counselor, the clinical psychologist, and of late, which really makes me quite hopeful of things, is that then I see people referring to the psychiatrist, people coming to see me, I'm always curious. So why are you coming now? And I get the feedback that, I've been seen by a behavior therapist, I've been seen by a counselor, and they said that it's time that you see a psychiatrist. So I thought that was really good, right? Okay, so there is some hope there. So in terms of psychiatric disorders, these are abnormalities or difficulties. Yeah, abnormality doesn't mean out of the world. That means your normal is like this, and then you have some abnormal emotions or behaviors, people that struggles with academic or difficulties relating to others, which must be severe again, persistent, and causing difficulties in the child's functioning. Yeah, and it's distressing to the child or to people around them. And again, it impacts the child's development. So this is the definition there. Yeah, any difficulties of behavior, emotions, learning, or academic, or interacting with other people, or in many of these kids, they actually have all. If you look at it, all these disorders, by the time they come or they need help, they will have all, which is again, a definition of what mental disorder is in terms of a medical condition. Yeah, because as I always say, we only have one brain. And if this brain is affected in terms of focusing, for example, focusing will definitely affect academic. Focusing would then academics would then affect emotions and behavior over time, and thus relationship. So you can see this is all interconnected. Yeah. Okay. So why should we be concerned? Well, why should we be concerned? As what I said earlier, but the prevalence in a developed country is 10 to 20% of children, but it is thought to be more in the developing country because underreporting. People are less being seen in the mental health services, right? Okay, and again, you see the increase with the pandemic. I was still working then in UNMC, and I can see the increased number of people presenting with mental health difficulties, particularly emotional and behavior and academic, right? So in many of these countries, it has become a public health crisis, actually, right? This is worrying. And Kressler had said that if you do not pick up by the adolescent years or puberty, right, it will worsen, which again, this is true. This is something that I experienced myself. You can see the learning problems worsening, the behavior, and definitely depression and suicide. Even the bipolar and psychotic disorder appearing and worsening, right, if it's not picked up early enough. So now, the first thing that I also would like to mention here is that even though we are in developing countries, even though our psychiatric child and adolescent services are trying to cope with an increase in number, I think we are, in terms of treatment availability, I think we're quite on par with other developed countries or developing countries. However, because of the low understanding and acceptance, then we can see falling out. They stop coming, they stop treatment, and that's why when they stop coming, they stop treatment, that's why by the time they reappear in the mental health service, i.e. in the adolescent years, you can see that the number of depression or suicide increases. Okay. So these are just things that I thought I would like to state, is that why should we be concerned? Because we need to do everything possible. I always say everything possible before the child turns 12 or puberty, because by the time they become adolescent, right, parents and homes are less concerning for them compared to their friends or friendship, right? Every step we need to take necessary to make sure that the children come from a supportive environment. Unfortunately, and again, this is through my experience, many children grow up in an environment whereby their developmental needs are not met. and I will talk about this later. And when the developmental needs are not met, yeah, there is an increased risk of psychiatric disorders in them. Okay, same thing again. Okay, all right, pause.
Yes. Okay. So this is very interesting. So just to clarify to some of the parents, yeah, some of them ask questions. But before that, let me relate some of my experience with Dr. Aili. Yes. So it's amazing how Malaysia, in terms of psychiatric care or mental health or psychology or psychiatric department in hospital is widely available, but it's just that they are tucked in properly, nicely, and it's hardly you can hardly find them, but it's okay as long as you ask. And also the thing
as long
is
as you
that,
ask, you're correct.
Yeah, correct. Because I do experience like what Dr. Aili experienced, because by the time the parents come to me, the child is already in a way that it's very hard to do counseling, because as a counselor, just to clarify, we don't do diagnosis. We don't do any type of assessment. We only screen. So by the time when we screen the child or the parents with a very simple depression or general anxiety tools, we can see that for the past 2 weeks or so, anxiety and stress level are very high. And then this is where I have no choice but to refer, okay, because I don't do diagnosis. I cannot follow through the treatment in a way that, and in a way that counseling itself is sufficient, because when someone is not happy or incongruent or in the state of anxious all the time, how can I talk to them? It doesn't make sense. It doesn't make sense. So that's the reason why we have to refer to a psychiatrist. And as for clinical psychologists, they can do diagnosis, but sometimes if the child, for example, they are diagnosed with disorder, no longer mental health problem, this is where some of the disorder require medication. For example, depression. If in the early stage of depression, yeah, the chances of not having medication is lower as compared to those, from mild to severe. So it's a combined treatment. So this is where misunderstanding, like once you take medication, you still can continue your talk therapy with your clinical psychologist or counselor, because this is part of a treatment plan, and it's proven, it's evidence-based. Okay, it works every way. I would say that not one therapy is standalone. You can be combine everything. And then another thing I myself experience is premature withdrawal. Okay, in a way that they stop. Once they seen a psychiatrist, they took the medication, they feel good, they stop seeing me, they stop seeing the psychiatrist, and then this is the thing with humans. It's quite interesting. They always a relapse. Okay, this is something that I always tell parents, especially mental health, and any health. Like for example, you have a fever, a doctor say take antibiotic, but you stop taking after you feel good, and then down the road you feel sick again, and then when the doctor asks, did you finish your antibiotic? No, because I feel better, so I don't take my antibiotic. So same goes with mental health services, okay, counseling, medication. You cannot just stop without consulting or talking to the therapist or the psychiatrist. Yes, I know sometimes parents are worried that when the child is under medication, they are less active. Okay, but that's the work of medication, because before the medication, some of them, they said the child is very active or very hard to control. After medication, then the child become mellow, very slow. I mean, yeah, so give and take. While the child is on medication, you can, like what Dr. Aili shared just now, you can teach them some skills, expose them, because they are under control. That's the work of the medication, and it's no wrong in doing something. Sometimes by doing nothing, it's also doing something. Just let the medication kicks in, and then and then you can work with your psychiatrist. So these are the what do you call this? Misunderstanding I experienced that I can relate to Dr. Aili. I mean, it's good that parents ask and know where to go, what to do. Because I have one question here. A parent asked, when do I know I need to see a psychiatrist?
Okay. Yeah. Okay. I go back to here. This definition. The abnormality, is severe and persistent, and it causes functioning difficulties in functioning.
Yeah.
Be it is the child or even in the parents.
Yeah.
Okay.
Yeah.
But I must say though, even though I because Charlie did say earlier, even though I'm a psychiatrist, I'm also trained in psychodynamics. So unlike some of the psychiatrists who are in my age group, I do as well the talking therapy. And it's really good to know, because the younger psychiatrists are also interested in, they do family therapy, they do EMDR or something like that. So they are also, the younger psychiatrists are also interested in not just medicating, but as well as to offer service of individual work or the talking therapy.
Yep. Yep.
Okay?
Yeah, correct. So one of the common thing, because mental health is already something that is quite complex before COVID, before the MCO. So a lot of things like after MCO, here I myself have witnessed some of the child and parents who are not in the traditional way of getting mental health difficulties. So a lot of the family dynamic have changed, the work condition have changed, the school have changed. So this is where one of the things that, okay, parents, if you're worried to talk to a psychiatrist or a counselor, you can talk to your GP, your family doctors, or even pediatrician, and then they'll explain to you if you ask. That's the most important thing. Please ask, because if you don't ask, there will never be an answer. And then also sometimes I have parents feedback saying that, oh, there's no walk-in, you cannot find the psychological ward or things like that, or psychiatric ward. This is part of the government movement, okay, to reduce the stigma. You know, when people walk in, people around you start looking at you, oh, you see that person, he's walking into psychiatric department. So they are tucked in nicely within the hospital area. And you can see, if those who've been to psychiatric department in you can see it's nicely tucked in one corner, and it's I know it's hard to do it. And then also previously, if I'm not mistaken, before COVID, do provide walk-ins, right, doctor?
No, there is still walk-in.
Okay.
It's just that we have limited the number because there's too many. You
Mm.
just cannot cope.
Yeah. And then you have other general hospital, like Hospital Shah Alam. You can just talk to them. And then costing wise, government we are heavily subsidized. You will not believe how much it costs to see a psychiatrist. It's only 5 ringgit. If Dr. Aili is still in the government, you can see her just for 5 ringgit. And then that includes medication. So this, it's not very expensive, but it's just that you need to ask and you know where to find, because these are the things that we have as a mental health professional. We have difficulty speaking out. Why? One thing is, from my experience, is I need to protect the PNC of the family that see me. I cannot go out and announce, hello, I have parents here seeing me. I cannot. So, but the thing is,
you can't.
Yeah, so this is where we provide, like my story, we have this platform for parents to know what are the alternative choice, and it's scientifically proven. Okay, it's not pseudoscience. It's not, I mean, it's not very traditional in a way. I believe there's I've heard parents who come to me where they have seen traditional doctors, but it doesn't work. Yeah, but it sometimes works, sometimes doesn't. But this is correct. So this is where we will use science to identify, like what Dr. Aili have shared, the difficulties. And then one more thing that parents ask, why do my child have to see a psychiatrist when he used to see a pediatrician?
Okay. I think what Charlie explained in the beginning is actually correct. If your child does have got okay, let me go to my presentation, and I think it might be clear here.
Yeah.
Now,
Okay, sure.
when I talk about here is the different scenarios. Yeah.
Mhm.
Now, what does it mean? Right, children. If you divide the childhood stage, it can be in the early childhood. Yeah, below 6, and then you have 7 to 11, and then you get why 11 or 12, because now I think puberty hits very early. Yeah, then you go into the adolescence. Yeah, all right.
Mhm.
Okay, now children with severe developmental delay, you can pick it up in early childhood or even sometimes at birth. All right, but children with other scenarios or less severe forms of disorder, yeah, you can only pick it up in the middle childhood or sometimes in the preschool years. But because preschool years is very early, and a lot of parents or even teachers will say, never mind, let the child grow a little longer. So things that have appear in the, let's say, preschool will become more prominent, yeah, in the middle childhood stage, right? And it definitely becomes significant in the adolescence. What can you see, right, in terms of developmental delay, social, yeah, learning. And if you don't pick it up, it will be added with not just learning, behavior, and emotional difficulties. Okay. Now, if the child is born early, if the child's difficulties can be seen at birth, usually the pediatricians will be able to handle diagnosis and assessment and handle care. It's just that now, even among the pediatrician, there is the developmental pediatrics. And the developmental pediatrics compared to the general pediatrician, yeah, it is the developmental pediatricians that are able to pick up developmental delay, which includes things like autism or a child with ADHD. Okay, so you will have this experience. Definitely, if you bring to see a pediatrician, right, they may say the child is normal, and if the problems are persistent, they will actually recommend to see. Even I recommend to see a developmental pediatrician first, especially if the child is very young, right? And what the developmental pediatrician will do, they will do various investigations to be sure, right, the child is thoroughly assessed, and then give the recommendation of what the child needs. Okay, so now that's one. Two, now remember when I said earlier, there is a difference between the adult psychiatrist, the general psychiatrist, and child and adolescent. Again, similar to the pediatricians, developmental pediatricians, this is what we do, and this is what's happening in the field of psychiatry. It is the child and adolescent psychiatrists that will be able to detect these other deficits or delay or difficulties. It's not easy unless you can clearly pick it up in a child when you look at it physically. But otherwise, many of these psychiatric disorders is very, very tough to pick up. The other thing, well, I do my assessment via a history taking, meaning I sit down, I take a history, all right, and people are actually thinking that I'm having storytelling with them. In actual fact, no, I'm doing an assessment, because usually when I finish my session, I tell them, I think your child has got this, and the parents will say, when are you going to assess my child? I said, I already did. Yeah, so that's the other thing. And I think one of the things that the parents are maybe worried about is, but that's how we do it. We, in our training, we have to come to a conclusion or a workable diagnosis within that 45 to 60 minutes. Yeah, we cannot go on and on and on doing an assessment without having a diagnosis to work on. Now, this is a diagnosis to work on. It is not a diagnosis that we can confirm, because many of these childhood disorders changes, or you see more symptoms as the child grows. Okay, for example, right? In the early childhood years, yeah, you can see a child who's slow to walk, slow to talk. That's easy to pick up. But some children who are able to walk, they are able to talk. Then when you go into preschool or primary school level, then you can see it. The slow in learning, the problems in interacting with peers, or even the speech. Their speech is limited compared to their peers. Yeah. Now, I used to say that the education system in Malaysia really helps me to assess children, because you can see standard 1, standard 2, standard 3, standard 4, standard 5, standard 6. You can see how the academics are very different at these stages. And children that do not go through or cannot go through further, or as they grow higher, they deteriorate in their functioning. To me, that's usually an indicator that there is something in terms of their learning that needs some attention. Okay, so you can see it progresses. That's why I do storytelling in that sense, yeah, because you can see as it goes here and into the adolescent, you see more difficulties, and these difficulties are not in isolation.
Yeah,
right?
correct.
It is because of, is what Charlie says, we have only one brain. It's just that the appearance is different.
Yeah.
So it becomes like this. Now, this is another scenario that I come across, yeah, whereby the child may be normal, manageable in the early childhood years, whereby preschool, for example, right? And that's why when you ask the parents, what did the teacher say? The teacher says, they're a little slow, but you can only manage, yeah. And then when they go into the primary school, don't forget the learning changes into primary school level, then you can pick up more symptoms. And more symptoms will be picked up in the adolescent. So it might just be some learning, some behavioral difficulties, but as they go into towards adolescent, then you can see the behavior worsens, the learning deteriorates further, and the emotional difficulties appear. So these are the different scenarios again, right? So the normal, I put inverted commas because a lot of people say, don't worry, he's a boy, you will pick up. Oh, don't worry, well, he looks well, why? He's like everybody else, right? But then you ask them, what actually did the teacher say? The teacher says he's not focused, he's daydreaming. And then you will see the difficulties picking up, more and more difficulties that can be picked up, but minimized or dismissed as the child grows older. So this is what I'm trying to say here, right? You might not see the delay or developmental delay in the early stage, but you can pick it up as the child grows older. Okay, this is the other scenario, yeah? The other scenario, and this is the reality in schools. Many of the children are struggling with their learning, behavior, and emotions, right? But we don't know what is going on. So they continue to struggle as they grow older, yeah? And you can see them, the academics drops, yeah, as they grow older, okay? So, and we always say this is normal. So what happens here? They're not identified. So what happens then when they're not identified? They are struggling, right? Especially if they go from one year to another and they are struggling. So when they are struggling, it means to say that the difficulties are not going away. And so what happens then? Right? These are in children with normal intelligence level, okay? Right? Children with intellectual disability is different, right? Autism is different. These are kids who are, in terms of their level of intelligence, is intact, but they have learning and behavioral difficulties. And we don't pick that up early, yeah, they become disinterested in their studies. Usually by standard 5, standard 6, right? And when you don't pick it up early enough, by the time they reach high school, then the problems worsen. They become uncooperative, they skip school, and they gravitate towards all these negative things that we hope does not happen to any of our kids. right? So
Yeah.
in some scenarios, they are stressed, they cannot make the expectation, and they become depressed or anxious. And the other scenarios is that they become more behavioral difficulties, they are uncooperative, defiant, and puts a stress on the parents and teachers, right? So what happens then? Stressful parents and teachers, we will punish them, we will give them negative comments, we label them. Again, that will give rise to uncooperativeness, which will then stress the adults. So you can see now, this is what I have been hammering or trying to hammer home for the last couple of years, to what we need to do with kids with learning difficulties. Instead of labeling them, we should figure out if they have difficulties. Because 35% of children with learning difficulties will drop out of school. Yeah, 62% of them will become unemployed, right? And there is a very significant links with learning disability and substance use or oppositional behavior,
Yep.
right?
Yep.
And again, it's going to cost us the juvenile delinquency, substance use, yeah, breaking laws, and so on and so forth. Okay,
Yeah.
pause.
Yeah, that's very good information, Doctor. So it's very good that you bring up learning difficulties. Okay, this is what I've been telling parents as well. You don't see like there's number of parents that I've met, you know, when the child are 3, 4 years old, they don't see any difficulties, but 5, 6 years old. So this is where I'll explain to parents in the way that that's why it's called learning difficulties, because if you don't send a child to school, there's no learning carry out, then you don't see
Yes.
any difficulties. So it's pretty straightforward. And sometimes this is where parents have to understand learning is a very complex cognitive skills. It requires a lot of your brain functioning and your body parts work simultaneously. Your eyes, your ears, your nose, your sensory, everything. So if one part of it is not addressed, this is where one of the parents asks, needs not met when child is young. Okay, for parents that ask this question, it's not about whether the child have adequate food, you treat this and that, but these are like what Dr. Aili have explained, the social needs. Okay, as simple as seeing the child having difficulties. Okay, sometimes the child, like what Dr. Aili said, if the child have difficulty in learning for over the years, I think it's a time where we put a pause and check, because I have met some parents feedback from the school that the child has difficulty and then sent to tuition, it got worse. It's not that the tuition is not working, it's not that the school is not working, but it's time for us to put a pause and understand the child. This is where for parents that who ask needs not met, this is one of the needs are not met, because it's an obvious signs that the child is unable to cope. Okay, you can see that in the early years, they don't show any behavior. All these are learned, so they pick up. Okay, and then yes, another parents agree that not agree in a way that saying, yeah, her experience is psychiatrists, counselors are talking. Yes, we are trained to talk in a way for us to do some assessments as well. From my experience, mental health is unique. We don't have a machine, MRI machine, where we just put you in it and then the result come up. Okay, your mental health is this. So it requires a lot of history taking, a lot of talking. I'm sorry to say this. Some of the parents feel like they come and see me and I just ask them how they feel, which is quite important for me, because as a counselor, we need to identify your emotion, and like what Dr. Aili have shared, it's part of the assessment. We have time limit. Within that 1 hour, we need to pick up as much information as possible, and then that information will guide us to do what's next. So
can I just interject? Okay,
yeah,
even
sure.
though even I'm a psychiatrist, as what I said earlier, I'm trained in psychodynamic. Yes, I might talk during the assessment, but during the individual work, I don't do much talking. I do a lot of listening to try to pick up what I need to tackle. Okay,
Yeah.
so yes, people's understanding is psychiatrists do a lot of talking, but unfortunately, I don't. In fact, one of the things that I get feedback from my patients, my adult patients, are they're kind of scared to come and see me because I always say, "What do you think? What do you think we should do? What do you mean?" Yeah, so they get anxious because they are forced to think. And
Yeah.
that's what psychodynamic is about, or rather the work that I do. And
Yeah.
the work that I do, particularly with, okay, I would have to say adolescents or young adults. I do a lot of work with adolescents and young adults
Mhm.
who are able to have, who have the normal level of intelligence. Yeah, I do a lot of discussing about problem solving.
Yep.
Yeah.
Yep.
Okay. Now, what do I mean by needs? I will talk about shortly in my
Mhm.
presentation. What do I mean by their needs are
Mhm.
not met?
Yeah. And then I also found out that for the previous question, I think what I know is the reason why your child transferred to a psychiatrist is because in government, or I think in whole Malaysia, once your child hit 12 years old,
Ah,
they are no longer, correct me if I'm wrong, doctor. So from my understanding is after they're 12 years old in a government hospital, you are no longer under the pediatric care. So let's say if you've been seeing a developmental pediatrician, if your child have some is diagnosed with, for example, autism or ADHD or learning disability or specific learning disorder, this all will transfer to a psychiatric department. They are no
okay.
longer under what do you call this? A pediatrician. So this is where
Okay.
you can see Dr. like Dr. Aili. She's a
Okay.
child
Hang on.
adolescent.
Let me change that a little bit.
Yeah.
I'm not sure how it is in the other in the other hospitals,
Hmm?
but usually the developmental pediatricians and the child psychiatrists, they work together.
Hmm.
Things that the developmental pediatricians can handle, they handle. But there are
Hmm.
things that the developmental pediatricians don't handle, and we work together with them in terms of children with behavior difficulties, emotional
Hmm.
difficulties, or parents with difficulties. Okay,
Yeah.
but a pediatrician, yeah, will refer a child to a child and adolescent psychiatric services if they are not able to make a conclusive diagnosis of what's
Mm.
going on with the child. So there are two very different scenarios. I know my colleagues in PPUKM, and that's what we do in UM2. We work together with the developmental pediatricians. So our workload is not duplicated.
Yep, yep,
Right?
yep. And you can see from there you can see the developmental side, the developmental milestone under cognitive and emotional can be explored by a psychiatrist. So this is something that okay, this is another topic, but I'll just briefly touch on it. Some of the parents have come and told me that government hospital is not reliable, it's not valid, but these are the things that I don't see in private way. They work closely together in a team. So
But
this
why? Why the government hospitals not?
I have no idea, but I because to be honest, before I joined the center, I was with a private hospital as well. But this is something that I'm amazed with government hospital because they work closely. Although we don't see it, it's behind the scene. It's
Yeah, yeah.
behind the scene. Yeah, obviously it's government and the workload is very high. So you don't get to see the doctor as often, but the chances of you getting multiple doctors are higher as compared to private. Private, you have to privately hire two doctors, but under government, they work
Okay,
together. Yeah,
I'm just good. Just for toilet break. You can continue talking. Just give me 1 minute, okay?
yeah, can no
Okay.
problem. So this is where it's very important to know. That's why we have Dr. Aili to come in to share her opinion from a psychiatrist, because one of the things is heavily endorsed by the Ministry of Health is to make psychiatric treatment available widely across Malaysia. And this is why it's important for us to understand what is the function of a psychiatrist, what is the function of a psychiatric ward or department. So like what Dr. Aili have explained just now. So it can be any children or without any diagnosis, okay, or what Dr. Ailey say that it's inconclusive from a pediatrician, so that then they tends to refer to a psychiatrist. And also from what Dr. Ailey have shared just now, not her style of treating is not everything medicated. There's alternative, and also like you can say that she tends to talk or listen, and then only certain disorders that require medication, then she will provide. So for those who are worried or fear about medication, if you've seen a psychiatrist, please ask them. They can explain to you why they provide medication, why they do this, why they do that. Okay, and then also like lastly, before we move on to the next slide, mental health is evolving. It's faster than, in my opinion, it's faster than I anticipate. Like last year, I used, before I work with children, I used to work with people with addiction issues. It's evolving. It's even until now, and then it's closely related to learning difficulties and whatnot. So these are the area that sometimes I myself will tell parents that I don't know. I need to ask
Yeah.
a psychiatrist because I cannot rule out in terms of the medical side. Okay, I don't know. And then sometimes we require, parents require multiple visits to counselor, clinical psychologists, and psychiatrists because we, at the moment, we don't have equipment like the physical doctors or other medical field where we can just pop you in a machine and then you start generating, or we have scan that can scan your brain and know how's your emotion like. We don't have that kind of machine. That's why sometimes I understand why parents feel frustrated. Like, Charlie, why do I have to see you after 2-3 sessions? Very straightforward.
Because to see whether you're well.
Yes, yes,
It's
yes.
to see whether we are well.
Yes, because sometimes history taking take quite some time. We cannot finish in 1 hour. I mean, I'm just a human, only one brain. I cannot, when I have multiple inputs, I cannot process. So that's why I work closely with a lot of parents like us. Oh, you work with psychiatrists, or this means the group of you have something wrong. No, it's not something. We are in this field. I need to work with the doctors because I need to understand from the medical point of view. Psychological point of view is not enough. And especially now, the children, like what Dr. Ailey have said, once they go into, you can see the one that Dr. Ailey shared, as they grow, you can see the round thing. It's correlated and it's overlap. So it's carry on. It's not like one off, finish, and then you move on to the new disorder. It's not. It's a build up. So that's why when you see a psychiatrist or you will see a counselor, or they always say that most of the time they will say that like depression, it doesn't develop in 1 day or 2 days.
Definitely.
Yeah, it accumulate, and then the reason why I and like Dr. Ailey today, we harp on children is because we need to start early screening or early detection, so that it's down the road, we know what's going to happen. And if we know, like now the situation, we can anticipate what will happen next, and we can prevent. A lot of time, like Dr. Ailey said, mental health is preventable, and some of them has cure. So yeah, the only thing is we need to learn from like doctor point of view today, when she shared about a child is normal in a way that, you know, the intelligence are not below or not too high, but they are intact. Okay, this is where the normal belong, but they still have mental health difficulty in terms of they struggle in school. So you can see, for those who missed out, you can replay the video later where Dr. Ailey shared a very good slide where you can see overlapping circles from childhood until adolescent. It's overlapping, and you can see this is what we call a manifestation. So from one thing, it grows bigger. By the time we see there's a behavior, it's not that it's too late. It's just that we don't know about this because parents are not in this field. So it's okay. So sometimes parents feel devastated or said like, oh, I should have come here earlier and whatnot. But I mean, it's okay as long as you get you speak to a psychiatrist, you talk to them. Yeah, we are not weird people.
Yes. Okay.
Yeah.
I'm going to continue because I want to get to where I want to get to.
Okay.
Okay. I'm not going to mention a lot about this. I'm just going to talk about some common disorders or some common terminologies which you might have heard. Yeah. Now we talk about neurodevelopmental disorder, psychotic disorder, mood or anxiety disorder, externalizing or behavior, or you call it disruptive behavior. Then we have substance use and other things like eating disorder, tics, gender identity, and internet use disorder. Okay. Again, these are some terminology. I'm not going to talk in depth about this. Just to remind everybody, there's some things like intellectual disability, or what people talk about learning disability, ADHD or ADD, autism, speech impairment, tics disorder, and so on and so forth. Okay. Right. Now, what is neurodevelopmental disorder? Now, neurodevelopmental disorders are disability or deficits which are primarily, it is neurological of origin. I mean, it happens because of things that's happening in the brain, right? And we just don't know why it happens, but it does happen in some individuals. Yeah. So they will experience, children with developmental disorder will have language or speech, motor skills or behavior, memory, learning, or other neurological functioning, right? Like weakness, for example. And many of them will have a combination. It's not just one, right? And the symptoms usually, as what I said earlier, yeah, you might not pick it up early, but later as the child grows. So the disability are usually permanent. An example would be learning difficulties or focusing difficulties or autism, for example. And diagnosis and treatment is very difficult. Okay, so the understanding is the medication does not cure, but the medication can use to control some of these difficulties. And the treatment is usually a combination of therapy. Okay, that's why, because it's neurodevelopmental, yeah, is what it says here, it will be throughout the life of that individual. Then sometimes the therapy may be lifelong, but it might not be all the time, but periodic. Yeah. Okay. And from here, okay, some factors will be hereditary, intelligence, temperament, or the environment, definitely low birth weight or premature birth, and if a child has got physical illness, some contributing factors. Yeah. In these childhood disorders, yeah, we cannot pinpoint specifically why the child has got difficulties. But we see a high prevalent but low severity in kids with ADHD. You see a lot of kids now with ADHD, learning disability, and low prevalence. Occurrence is lower, but definitely high severity or impact is children with mental retardation or intellectual disability, cerebral palsy, blindness, deafness, and so on and so forth. And they would definitely need appropriate intervention in terms of schooling. Yeah. Okay. The other contributing factors, yeah, contributing factors. I'll show you this way, like this. Yeah. What does it mean? That means the child develops or is born with some form of neurodevelopmental disorder. Yep. And there are contributing factors, particularly in terms of the environment, maternal mental health, right? Or there's something happening in the home whereby emotional dysregulation is emotional regulation is not learned. Yeah. And the other bigger things in the bigger population, right? So contributing factors, definitely if there's presence of abuse and neglect, definitely in presence of primary support group. And this is what I mean by what are the needs of a child. The needs of a child is not just a home. The child needs to have warmth and support, a safe environment. And what we find, even in our local population, yeah, there's disruption not just by divorce, separation, or parents who are still together, but they live in a conflictual relationship. Yeah? High
Yep.
express emotion. This is the other thing that I find is that when we have a parent or parents with a lot of negative affectivity, that means they're just constantly worrying, cannot do this, cannot do that, right? Very critical parents. Yeah. High expectation, for example. So these are difficulties which will contribute, definitely will contribute to the child's mental health, including the parent-child relationship. Yes, and other difficulties in the environment. So it's not just why is the child not happy, right? Parents will always say to me that we stay together because for the sake of the child. But if their relationship is not or is still with conflicts, it is very difficult for the child to stabilize. Okay, and these are the red flags. Yeah, presence of marital disharmony, the frequent use of threats, intimidation, and aggression. Yeah, one of the things that I find, especially in children, yeah, especially when parents say to them repeatedly, right? If you misbehave or if you don't do things that I want you to do, you can get out and leave. Right? And if you ask the parents, they might not remember. Or you ask the parent, oh, I see it because I was angry. But the impact on the children is that they are left abandoned. You get out. It's a very, very rather traumatizing sentence for a child to hear. Get out of here, right? I don't love you. You don't love me. All these kind of, I think it's kind of intimidation. Yeah. And if there are depression in parents with or parents with mental health issues, or the use of substance use and abuse, and if there are learning difficulties, when I talk about learning difficulties, it's not just the dyslexia, but what is often missed is ADHD in children with learning difficulties. Yeah. Okay. So these are presentation. They can present with. Remember what I told you, the different stages of children. Yeah, they can present with developmental delays or learning difficulties. They present with speech and communication with others, or behavior or interaction with others. They have difficulties following or staying focused, following or remembering instructions. They have difficulties with mood and thinking, anger, aggression, and parents or parenting styles which is less than ideal. Or all of these are quite common in the children that I see. Okay, right. So sorry. So just to remind everybody, right? Areas of emotion, academic, behavior, development, or interaction with others. Right. When do you see someone, especially when these difficulties they continue, they're increasing in frequency, right? And it affects the child, right? Okay, now I would just like to mention about intellectual disability. Again, intellectual disability is something which is, again, not well understood, is dismissed. Yeah. Now, a child with developmental difficulties, depending on the level of difficulties, now a child with mild to moderate or just borderline IQ impairment, right? You can see, even they appear to be normal, but for me, it's easier for me to pick it up because of the years of training and experience that I've had. Now, a child with intellectual difficulties, what does it mean? They have difficulties in terms of the intelligence, right? Intelligence and adaptive skills. Intelligence means, can they understand in terms of their thinking process, right? Now, why it is misunderstood is because possibly the child is growing, right? Many of these kids, they can speak, right? They can learn, but their learning is not as of their age group. And that's why a lot of parents say, no, but dia boleh cakap. But what is he talking about? Is he talking as a child of 15, for example? Yeah. And these are the children that when I say to you, there's a lot in the schools that they are not picked up. Right? Do not forget, concept is understanding, thinking process. Understanding, remembering, can they reason and can they adapt? Right? And it's easy to see, right? If you see the child is 5, 6 years old, 7, 8 years old, you can see whether they are developing or they have stalled in terms of them understanding, utilizing, reasoning, and adapt, right? Not just remember, reasoning and adapt, right? And the adaptation is in terms of looking after themselves. Can they get up by themselves? Do they know the time? Right? Do they know when to do the homework? Do they know how to do their homework? Right? And many a times, I think because we try and help them along, right? And we say that they know, but if left on their own, you can see it in terms of their academic performance. They're not progressing as their peers, or they have stalled. Or the understanding, you can see it. The understanding is very, very simple. Okay, so I put this up here because people say this is a learning disability. Yes, it is a learning disability, but the learning disability is different because it is the IQ that is not developed, and therefore they struggle. And kids like this is what Charlie says, it's very difficult to have this talking therapy with them because they don't understand what they're supposed to do, right? So we can send them to tuition, and if it doesn't improve, then we need to think about what's going on with these kids. Instead of scolding them, I spent so much money, why you're not improving?
Yeah.
It's because that we're missing this.
Yep.
Yeah? Okay. So this is a common scenario. Right? The story of children who are struggling to cope with the normal education. Okay. And these kids are struggling to cope as per normal their age. Okay. But we're not picking it up. I'm just putting it up here for the different range. Okay. And the consequences, they have academic, behavior, developmental, and emotion difficulties. Okay, pause before I go to my last thing that I would like to cover.
Okay. All right, doctor, we have a question. Can neurodevelopmental disorder be inherited?
Can.
Okay. All right. So parents, please, although it can be inherited, but please do not blame each other, like your gene, my gene, and things like that.
Yeah, it's not easy, you can't.
Yeah, so I understand this because on the previous awareness talk, we have a parent support group as well, where they share their experience initially when they got the child. Yeah, it's no doubt we are human. We start questioning each other, like, is it your gene or my gene? That we like what doctor said, it's a lot of things that we still don't know. I mean, like, yeah, like how do I know is it's my gene or your gene? But I mean,
Yeah.
it's very detailed. So yes, it can be inherited. But I always ask parents, let's say you want to take a step further to test on your genetic, but what's next? Okay, for what purpose? For you to blame your partners, your spouse more, or just to dispute the conversation that, okay, it's obviously your fault or things like that. So yeah, from the medical point of view, from what Dr. Aili explained, yes, it can be inherited, but it can be inherited, but it can also be helped to support the child. But like what Dr. Aili have shared just now, it can be worsened through environment. So this is where the next question is, Dr. Aili, nurture versus nature, which one contributes more?
We cannot say that. We cannot say what contributes more. It's so dangerous to say. Okay, maybe make it. Wait, hang on for a while. Okay, maybe that I'll give you something to think about. Okay, let me continue just first with my presentation. Then, oh wait, hang on. Oh no. Wait, so maybe this can give you something to think about. Just give me a minute.
Yep, sure, no problem.
Okay, now this is something which I I would say something which is my interest, depression in children and adolescent. And this, my interest in depression in adolescent and children has been there even before the pandemic, and partly because I see a rise in number of children who are depressed pre-pandemic actually, and the numbers increased tremendously during the pandemic and post-pandemic. Okay, now why I thought that I would like to talk about this is because a lot of people, a lot of adults feel that depression in children is not real. Depression in children is actually very real. Yeah. And again, the mood disorders in children is becoming more common. It is a psychiatric disorder, which is, I think for me, when I see children who are depressed and they're suicidal, it makes me feel very worried because I need to try and get the kids out of the acute state. Okay. And depression in children, yeah, it's very important why we have to intervene, because it results in impairment in their functioning. Right? Now, depression in children, these are the studies have shown that even in the pre-pubertal stage, 11, 12 years old, kids, they can be depressed. It increases in the adolescent. And we see more girls than boys, but I think the boys are also depressed, but I think they don't come to the service. Now, the lifetime range is about 15 to 20% of adolescents, and it is comparable to the adults who are depressed. Okay, and in fact, many even this I see in my practice, is that many of the adults were already depressed in the adolescent years. Okay, now it is a recurring condition. It can remit. That's why sometimes they come into the clinic later, but it recurs, and that's why they will eventually turn up in a mental health service. And the average episode can last from 7 to 9 months or even longer. And sometimes you can see it lingers right into the adulthood. Okay, and the predictors of recurrence are poor response to treatment, severity, chronicity, episodes, yeah, comorbid, family difficulties, that is the nurture versus nature, right? And so on and so forth. Now, I added in this, the negative cognitive style, right, whereby the environment is so negative, right? It's so difficult here. And these are some of the risk factors: parental depression, family discord, again, parent substance use, criminality, and definitely child abuse and neglect, right? And because of the environment, yeah, don't forget the child grows in that environment. So the child will think that this is the normal way of thinking or communication. This negativity, it impacts how they view themselves and how they view the world, and which would then give rise to risk of anxiety. And there is always a comorbid anxiety disorder, post-traumatic stress disorder, conduct or behavioral difficulties, ADHD, OCD, and learning and school difficulties. So you can see that these conditions can appear very much earlier, before you can see the child being depressed. Yeah, so this a risk of comorbidity, and invariably that's why many of the kids end up with medication, a lot of medication, because we not only have to treat the depression, anxiety, but as well as, for example, ADHD, for example. Yeah. Okay. Now, this is what we see, or what I see in many of the kids. They are depressed, and which makes just medication alone is not adequate. They need to come in for therapy, because we need to change. We need to change this, because they have difficulties with their self-esteem, self-direction, and self-regulation. They come from an insecure attachment or insecure environment, which gives rise to difficulties with trust. They don't learn how to adapt and cope appropriately, and therefore their problem solving and focusing difficulties. It's difficult. So it's not just Medicaid, or it's just not talking therapy. For example, there are many things that which the talking therapy needs to handle. Okay. Now, remember what I said, I've seen this already before the COVID, and then the COVID happens. And when the COVID happens, and that time is I was working in UMMC, we saw so many admissions. Yeah. Because with the pandemic, right, is what Charlie said, yes, there are family difficulties in school when hybrid, everybody was in chaos, nobody know how to do hybrid, right? And at the same time, it causes also a loss of unstable family support or a support group, i.e. friends, for example. And therefore, the risk of depression and anxiety increases. Okay. Now, what happens here is that this is where the nature versus nurture, right? The difficulties were already there. The family was already unstable to begin with, right? But you only periodically see each other because you go out to work, you go out to school. But when the pandemic, everybody is close at home. Boom.
Yeah,
Right?
correct.
Yes.
Volcano.
Yes. So it further destabilizes the family environment. Okay. So that's the problem. So what happens here? What did I say? Right? The difficulties were already present. What was already present, and it's really worrying was that there were life events and stresses that was already present in the family, which was not spoken about. And these life events or sometimes stresses amount to, for example, molestation or abuse. Ironically, not necessary by the direct family, but extended family. But it was just kept or not spoken about because this is what the society is about, right? We keep quiet, we don't tell, right?
Yeah.
And therefore, when you're all sardined together, definitely, right? I always say, like the pail of water, there's only so much that the pail can contain. And when the pail cannot contain, the water will spill out. And this is what happens with the pandemic. Right? So you can see, as what Charlie says, our job as mental health as professionals is not easy. It's not just one pill and everything goes away. No, we can't. Yeah. So I always say, this is why I always say, if you need the children to stabilize, I always point to the parents. Then the captain of the ship needs to stabilize. Yeah.
Correct.
If the captain of the ship is not stable, where would the ship go? Or how would the ship travel?
Correct. Yes. I do
This
agree
is
with
what
you.
I meant. This is what I meant by the needs of the children. And you'll be very surprised. Right? And for me, one of the many indications of needs of children is how we communicate with them. Yeah.
Correct.
All right.
Yeah.
Okay. So I'm done.
Yeah. So correct. So to add on the nature and versus nurture, as simple as I've seen a child come in and after COVID, they start hitting other children. This is where or they say some vulgar words, or they behave differently, not really aggressive. So this is where I sometimes let parents know, take a step back and observe how is the family dynamic, how is the home environment, because like what Dr. Aili have said, the child might see it as normal because for the past 2 years, both parents has been raising their voice at home. So so the child will be like, oh, it's normal. So when they go to school, they start raising their voice, and then they get detention and whatnot from the teacher. So these are the things that are small little things that sometimes we don't realize that it can play a big impact on the child. Yes, biologically, the child is there with a condition, but the environment can contribute, as in, predispose the child, like what Dr. Aili said, and then they see it as a normal and they do it to others. So same goes to like, I've seen bully cases, I've discussed with school and parents, there is a reason why the child start bullying others. It can be for them, they might think that hitting or bully other child is the way of life.
Yes, correct. And do you know what frustrates me? Yeah, we see the bully victim, we don't see the bullies.
Yes.
Yeah, because a lot of adults feel that doesn't matter.
Yeah.
It does matter. It
Yeah.
really does matter.
Yes.
Okay, to the parent who asks, which is worse, which is more, nurture versus nature,
Yeah.
I'll tweak it in another way. If you were to ask me which one I would like to manage more, I would say I would prefer to work with the adolescents than the parents.
Yes. Yeah.
Yes, it's difficult, isn't it, Charlie?
Yes, it is. So that's
Yes.
why so sometimes like I managed to get to talk to the bully and the family, and I can see that this is what I call sometimes a protective factors, because the
Yeah.
parents itself themselves are also behaving that way. So
Yeah.
to
Correct.
so for me, it's like a photocopy machine. So when you
Yes.
photocopy, that's what will come out. It cannot come out some other things.
Yes. And that's why, okay, my two favorite no, must have. Okay, my two favorite must have. My the other one is quite far for me to go and get. Is a tissue box for clients if they need when they cry, and for me is this.
Minyak kapak.
Yes. This is for me. When I had to deal with parents who are just not open
Yep.
to changing, actually.
Yep.
Okay.
Yep.
Okay, if I have my wish, and I think we really, really need this. Yep. I know you didn't ask me. But I want to use this opportunity. If I
Yeah.
had my wish, I think we should interject more humanity and
Yeah.
humbleness.
Yep.
Yeah, in our society. I think I don't know why it's happening or when it happened. I think we have lost this.
Yeah. I do
And
agree.
yeah, and I don't say it just for the kids. Even I get I get scolded by parents.
Same. Yeah. I mean, I
Yeah,
do experience that because yeah, experience wise, definitely parents have more experience than me, growing up the child. But what I mean, the reason why I stand my ground is because I'm in the mental health. So that's what I tell parents. I'm here to support and I'm here to help. I'm not here to argue with you, but this is what I
yes,
know. This is what I've been trained for.
yes,
And then, because in my story, for me, I don't only deal with individual. I work mostly also with family as a whole.
yes.
Because we are in Asia, we can't run away from family. So
Yeah, betul.
it's closely
I
related.
I stand my ground because this is what the sciences say,
Yeah. Yep.
right?
Yep.
And the
Yep.
science say it is us parents
Yeah.
to provide this, and it is very abstract, to provide this security in terms
Yeah.
of warmth and comfort, not warmth and comfort of expensive clothes. And
Yeah.
no, it's not
Correct.
that.
Yeah. So
Yeah.
sometimes as simple as like this is what I've seen recently: the child unable to
Yes.
behave according to the social norm. Okay. So the
Yeah.
social norm is being compliance at school. So as simple as that, I think a lot of parents or anyone that joined us today, we all experience being in school where the teachers say number one means number one. So if the child have difficulty complying, meaning that, we have to take a step back and see why. It's
You.
as simple as that. And I understand that some parents, due to religion, background, race, have difficulty open up and talk to psychiatrists. It's okay. You can always speak to someone that have experience meeting a psychiatrist. But this is what I want to tell. Do not compare children versus adult, yeah? Because
Yeah.
the adult experience with a psychiatrist is very different from the child.
Very good. Yeah.
So that's why when you look for a child psychiatrist, or you look for a psychiatrist for your child, make sure they are trained, okay, like Dr. Aili, or they have experience. Experience itself not enough, but it's an add-on to also academic knowledge. So that's why they have this title, child adolescent. Okay, like what Dr. Aili said. Firstly, she have to take special sub-specialization. So being a psychiatrist is already a specialization, but she take extra journey to pursue child and adolescent, because like if I ask someone who are experienced or have met a psychiatrist, it can be an adult. So the experience is very different from a child because the child in a way forced to go to, they don't know why they are there.
Yes. Yes. And for me, for example, in cases of autism or learning difficulties, I would do the assessment, right? Because the therapy with these kids, I send them off to a behavior therapist or clinical psychologists who are more expert or have the expertise to deal with this. Yeah, I do assessments mainly, but in children who need help in terms of the depression, anxiety, or ADHD, for example, yes, I do see them personally. But the other things, I'm not God. I had one parent who asked me a couple of weeks ago, don't you know that this is what my daughter is thinking? And I looked at her and I said, I don't know what your daughter is thinking. Oh, don't you do that as a psychiatrist?
Yeah.
I said, no, we don't.
Can you
So
all
it's
read
also,
minds?
yes. Okay. Thank you for bringing it up. Yes, Charlie, I would like to say I don't read minds. I can't read minds. I can read the story behind the story, but that too I cannot assume. I still need to have that conversation to be sure that my thoughts are correct.
Yeah. It's very important. There's sometimes when we talk about children, like nature versus nurture, sometimes I go very basic. Like we all gone through this in Malaysia education, the nilai murni, like the nilai tolong menolong. These are the things as simple as that. We all gone through this, but do we practice it? No, we don't. 90% of us, including myself, couldn't practice all. But this is the basic principle. Why I bring this up in terms of nurture is because a lot of parents come to me and say, you're not even married. You don't know how is it like to have a spouse and a child. So, but yeah, hey, so that's why I listen to your story, because I need to know how, and then this is how I support. As simple as basic communication, like, hi, how are you? Like, you know, it's hard. That's why we in a lot of family, I talk to them, and this is why we trapped in the cycle, because that's how our parents, our forefathers bring down. That's why it shaped the parenting skill today. But as an adult, we are the change agent. We change faster than the child. So sometimes if you embrace some of the nilai murni, you can teach your child that how to be human again. And then so
provided like what you said, provided we know what it means.
Yes. Okay. So
no,
that's,
because I think the other understanding is that children should respect their parents. But if you speak to the parents, you hear a different side of why they're not respecting their parents. Correct. So it's the pot and the kettle story.
Yeah, correct. So if you have, please reason to your child, because reasoning is very important. Sometimes
let me do. I do it the other way around. I know that we know. I always tell parents, I know that we know, but our child might not be thinking the same thing.
Correct.
So we stop and listen and try to understand.
Yeah.
Right? Instead of assuming that they do understand. No, they don't.
Correct.
They don't.
Yeah. So the level, sometimes we talk to our child, we have to bring it down, like, you know, so that we are on the same level speaking. It's hard. It's difficult.
Hard,
because these are the things that are not taught. We are not taught how to be parents at school, but it's okay. Now is the time for us to learn.
Yeah.
And then a lot of parents that I suggest them to stop saying that do as I do because I tell you so. I'm your father. So this is not reason. Okay, this is not reasoning. This is commanding. Okay, you are in a way threatening. Okay, like do as I say because I'm your father, and it's very different. And then when they do it on to others, and you can see where it comes from. So so that's nature versus nurture. So it's a topic where it's you need both. You can't be alone, like, you know.
Yes.
Okay.
For sure.
Yeah, and then we have a question.
So we done?
We have few more questions, Doctor.
Oh, okay.
Okay. So what can I do my child is diagnosed with ID. What can I do? Is academic no longer an option?
It depends on the level of intellectual disability and also um age as well, and what has the child been exposed to? Are they going to school? Have they got into special education? That sort of things.
Okay. All right. So for the
It's
parents,
it's not academic to excel, but more academic in terms of training, I think.
okay. All right. So for parents that ask this question, first, you need to know the level of academic.
Yes,
If
because
academic,
academic is teaching and academic is training.
Mhm.
And I think for intellectual disability is mainly for training.
Mm,
I mean, I'm going by the psychiatric understanding,
mhm.
actually.
Yep. So from my point of view is that just to add on to what Dr. Aili have said, you still can send to school, but the expectation to, like what Dr. Aili said, excel in academic performance, we need to drop that expectation. And also going to school is not only learning academic, there's a lot of things, social interaction and things like that. So this will enhance the child life skill. Life skill is not only academic, but others. Okay, next question. Can my child have schizophrenia at a very young age?
You can, but it's very rare. Usually onset is about 17, 18.
All right. So it's very rare. So parents who are worried, please see a psychiatrist. Yeah, schizophrenia is a quite
Rare, but
complex.
can.
It's a very
Betul.
complex disorder. Okay, because it's from my understanding, working with adolescent or adult with schizophrenia the person is like ADHD. It's very normal. You wouldn't know until there's an episode. So that's my understanding. Okay, the next question. I'm a mother of two. I'm on medication, and my firstborn had diagnosed with a disability. Recently, my secondborn became more restless in terms of emotional. It's a girl. And then teachers have shared that she disliked the brother in school and then have difficulty coming down after crying. Should I be concerned?
Should you be concerned? Go back to my slides and see.
Okay.
Ah,
So
go back to my slides and see. And see
so,
whether you should be. I see Charlie's laughing.
so for these parents, yeah, I'm glad that you open up and share. I assume when you said you're on medication, you are on a psychiatric medication. So I believe if you're on psychiatric medication, please speak to your existing psychiatrist. Should you be concerned about your child, and also, okay, and then also, yeah, and then talk to them and yeah, because I'm so sorry because by just such a short comment, I couldn't like explain more. But what we can do now is just to share our opinion, and then yeah, and then after this session, the video is available in Mind Story Facebook page, so you can replay and stop on the slides because today Dr. Aili we didn't go in depth about the types of disability because all those are pretty straightforward, but she did say the onset or how did it start, how does it overlap, what is the difference between the child difficulties and adult difficulties.
Yes, and I didn't want to go into that particular difficulties is partly because I don't want people to be confused or to make the diagnosis yourself. Just to think about if there are difficulties, then seek help.
Yeah, and then also one question is it all right for my child to take medication for depression at young age? If it's okay, how long?
Okay, that one you have to speak to your psychiatrist about it, and I'm not sure how young the age is. All right, and usually from the way that I work, we need to be on medication at least for about a year, and then we see how it goes. This is my experience. Okay, please go back to your psychiatrist to discuss this. Okay? And taking it off, we have to be very careful. We have to watch for relapse. We have to watch for stresses, and if the child is coping. Okay, and for me, I always tell the parents the major side effects is not treating the child when we have this opportunity to treat. Okay, because if the child is well, for example, now or can be well with medication, if we don't give them that opportunity, very tough.
Yeah. So from what I learned from psychiatrists over the years in the mental health profession, also when we talk about medication, I get this interpretation for those because it's sometimes we can't avoid jargon, but let me put it in a simple way, like a spring, a pen with a spring. If you on medication, you press on it. So after if you take off the medication suddenly, the spring will bounce back, which can cause withdrawal symptoms or relapse. So this is the reason why I always tell parents, please talk to your psychiatrist before you take off the medication, because it can cause a sudden shock to the body and to the brain and the chemical function inside the brain. So yeah, as simple as that, you can see it just bounce back like the pen when you click on it and you just release. So this is where the child can experience a lot of things. And if it's a child, then they have even difficulty in sharing how they feel. They are not like adult where we have more vocab, we can explain our situation. Okay, and we have one question. Okay, my child, 10 years old. Okay. Oh. All right. So recently he was caught, 10 years old, recently was caught looking at a picture of a lady. So and then he expressed that he has a strong interest in picture like this. Should I see a psychiatrist?
Go back to rewind the presentation. You need to decide.
Yeah.
You need to decide.
Yeah. So, okay. So for parents that ask this question, it's very good that your child is able to express to you. From what I seen here, I just assumed, correct me if I'm wrong, that your child able to express to you. So you have a safe communication with the child. So where the child can tell you, but if it's something that it's concerning you, please, you can look for a psychiatrist or child psychiatrist, or even your pediatrician to share this, because we don't know or what's the start or what's the end like. I mean, we don't know when he developed this, and then especially you said that during COVID. Okay, all right. So one last feedback from a parent. Hi, good morning, doctor. Just sharing. I've met Dr. Subhash Pillai, who took his time to diagnose my son when he was 4. He interviewed us parents first before starting with my son. From there, we as a family found out that my husband was high functioning. So when I found out that my son has autism, it was the most frightening moment of my life. But with the psychiatrist support, it helped us not to feel overwhelmed or frightened. Okay, thank you, parents, for sharing. Yes. We have a positive comment about psychiatrists. It's very good. Finally. Okay.
I always say there are positive comments about psychiatrists. But I think these people don't say anything about it. There's too many anti-psychiatrists. I feel scared. I will be scared.
Yeah. So correct. So I appreciate for those who joined our talk this morning. If you have any question that you don't feel comfortable, like some of these questions they have texted to me personally. So if continue to do this, if you have any question, we are more than happy to help. So we already at the end of our talk. So Dr. Aili, if they want to set an appointment to see you, where they can find you? Where can they find you? Because you said that you
Oh,
have retired from UMMC.
I'm in the mind faculty actually.
Okay, Mind Faculty. Oh, the one in Monkera.
Yes.
Okay. So for those who are interested and you feel like you can connect with Dr. Aili and you want to see her and set an appointment, you can find her at Mind Faculty at Monkera. She is available there. You can call, I believe you can call them up and ask about the available time. Hopefully it's not a long queue. Yeah.
No, actually, to tell you frankly, Charlie, I'm really surprised. I think my private colleagues, they're quite full too.
Yeah.
So it's like what you said. So the numbers are increasing and probably the awareness too.
Yes, because awareness on child and adolescent psychiatrists, I would say not as big as a general psychiatrist. Yeah, because if we see the population a lot in the geriatric, or geriatric is elderly, yeah. So adult to older, we have more population in that area. So maybe. So that's the reason why in Mind Story here we try to connect as many as child adolescent psychiatrists as possible, because yeah, because that's the alternative. Like for example, if the child has already been diagnosed by a developmental pediatrician, but they somehow somewhere have difficulty with their social interaction and emotional, this is where we suggest to parents that there's an alternative. The only one that I know of doctors are psychiatrists. Okay, we have others, but not. If we talk about emotional and mental health, psychiatrist is the one to go, because as a counselor and clinical psychologist, we have a limit. We cannot we cannot rule out the medical point of view. So that's the major difference. We can only see from one side, which is the psychological factors, but we cannot see beyond that. So that's the reason why we will have to refer. It's not like we don't want to take your case, but we already reached our
but
limit.
it does. No, it does make sense. I've had referrals whereby the parents will say, actually the therapist felt that they have done their best, but they're still not improving, so they want to have a diagnosis. I thought it's really good.
Yeah. Yep. Correct. So so this is the reason why we try to introduce this in the private centers, not only clinics. We make this available so that children with special need or people with disability, somewhere somehow they do have difficulty with their mental health. It's not end of the world, and it's important to have this, like the one that you have shared, the child since young, and then the onset of the mental health difficulty started as simple as learning difficulties, and then move on to preschool or primary school, where they have difficulty in what I call this, struggling with school, and then that's where we can see all the behavior and whatnot. So it's a journey, and then these are the things that let's say the child is being very aggressive. The only way to stop that that I can think of is medication, which can, it's like, oh, I have a headache, I pop some Panadol. It's way faster than I just rest and whatnot.
Yeah.
So the
good point.
So awareness is there. So now we have to take action. Okay, I know it's not something that we openly talk about, but by having this conversation today, parents out there or anyone out there or teachers even at school, you can suggest this. It's okay. We want to desensitize the community. It's okay to see a psychiatrist. If you can't wait for the pediatrician, it's okay. When you see a psychiatrist, when the psychiatrist say, oh, okay, I think it's not me, you have to see a pediatrician, it's okay. So at least you have someone to go to and someone to share your concern. All right. I think that's it for today. Thank you so much, Dr. Aili.
Thank you so much.
Thank you, everyone. Okay.
Enjoy the rest of your Sundays.
All right.
Thank you for inviting me.
All right.
Bye.
Okay. Bye-bye.